I want to welcome everybody to Hawthorn University's award-winning Holistic Health and Nutrition webinar series, and I want to thank you all for attending today's presentation with Dr. Mary Kay Ross on Alzheimer's disease, the silent plague, where we'll learn more about a 21st century precision medicine approach. You know, I'm just certain we're going to receive some terrific information with Dr. Ross, so be assured that this presentation is being recorded and it'll be available for replay on our website in just a few days. We'll also have time for Q&A at the end of the presentation, so write your questions or comments in the webinar question panel at any time, and you'll be in queue and in a good placement for your questions to be able to be asked. I'm Paula Bartholomew, one of the founders of Hawthorn, and so let's get started. Dr. Ross is joining us to discuss the current status of Alzheimer's disease in the U.S., along with the stigma and misconceptions associated with the treatment, as well as causes and outcomes available today. She'll review the known causes of the disease and the lifestyle changes necessary to help stop its progression. Dr. Ross is going to discuss how to evaluate a client with cognitive decline, as well as the labs and necessary workup for the proper evaluation and assessment, discussing how to design a program for a client, and then we'll conclude with case studies and outcomes. And finally, she'll share future potential treatments and adjuncts that will assist with ongoing treatment. So after the lecture, we all should be able to recognize a client with cognitive problems, assess the client correctly, be able to determine the drivers of the disease, and be able to initiate an appropriate workup and prepare a reasonable functional program for all clients with cognitive decline. That said, I want us all to be mindful of our scope of practice and to refer to qualified medical professionals for diagnosis whenever it's appropriate, because unlicensed health professionals do not diagnose, treat, prescribe, or cure. So if you suspect from your assessment that there's a cognitive concern, please refer out appropriately. You know, it's such an honor and privilege to have Dr. Roth with us and for me to be able to introduce her to you. Dr. Ross obtained her medical education at the University of Louisville School of Medicine and completed her residency training in emergency medicine in 2000 at Wright State, where she served as chief resident. And then following graduation, Dr. Ross worked as an attending physician in the trauma centers in both Virginia and Georgia, and has held faculty positions at both Eastern Virginia Medical School and Mercer University, teaching residents and medical students. And during this phase of her career, she realized that there was something terribly wrong with the current medical model, and that the hospital system was being overburdened by patients with chronic illnesses that were not being treated effectively. Well, then in 2012, Dr. Ross found herself on the other side of the medical system, suffering from a very serious mold exposure, and became a patient in the ER domain she oversaw. This experience would change her practice of medicine and her career forever, and she founded the Institute for Personalized Medicine, committed to treating her patients using functional medicine. In 2016, Dr. Ross teamed with Dr. Dale Bredesen, and together they applied her knowledge and clinical expertise with his scientific research gained from over 30 years in the lab. As a team, they sought to bring the best solutions to patients impacted with cognitive decline. Dr. Ross is also presently the founder and CEO of the Brain Health and Research Institute in Seattle, Washington, and is actively engaged in enhancing a multimodal precision medicine approach addressing all aspects of brain health. It's such a pleasure to have you with us, Dr. Ross.
Thank you very much, Paula, and it's an honor to be here. And this is certainly a topic that is near and dear to my heart. I think this is truly is a silent plague, and I'm very excited to discuss a new approach and give people hope, actually.
I'm so grateful for this, and we're all eager to learn more from your expertise that'll help us to really understand and implement the information. So I thank you very much, and I'm going to turn it over to you now.
Okay, wonderful. Thank you. So my hope is, you know, as we've discussed and as Paula mentioned, is to give everybody an opportunity to understand a little bit more about this disease. I really do believe we're in the middle of an epidemic. This is something that is affecting people all over the world, but predominantly America, the UK, Finland. We're really seeing the numbers rise, and I think that as we go through this, perhaps we can shed some light on why and what we can do to perhaps approach it in a better way. And I'm going to move forward. First, I'd like to indicate I don't have any financial relationships or commercial interest with anything, just a big passion for this. I think it's really important that we recognize the problem. This is my hope for everyone, because if we don't look for it, we will never recognize it. And I'm going to review cases with you that will explain this even better, because that's a big problem in the world today, is the recognition, and it's easily missed. The other thing is we want to understand the drivers. You know, when we look at Alzheimer's traditionally, and I'll mention this many times, but it's the treatment that that people use usually is focused on amyloid plaque or tau protein, and we're not really looking at the underlying root cause. So I know that my audience is a holistic background, which is great, because I think that's really what we need, is to be able to understand really what's causing it, what's driving it, and then perhaps we can remove it. Another thing I hope that I can impart is an appropriate diet, and understand why diet is so important, and lifestyle program to support the patient or client, I call them patients, and their family members, their caregivers. I think that's crucial as well. I don't think anybody is untouched by this in America. I mean, if you think about it, we all either probably at least know someone's family member that has Alzheimer's, but many of us are struggling with spouses, siblings, friends, and I think it's important that we understand how far-reaching this is. I'm going to start in an unusual manner. I'm going to ask you to do an exercise with me. I want you to close your eyes and think about, you know, imagine, if you will, that you went to a friend's party, you've been gone from town for a while, and you're in there talking, and someone runs into the door and says, "Oh, hello," and they're so excited, and they stretch their arms out to hug you, and you have no idea who they are. And you notice that this has been happening to you quite a bit lately. And you get a very unsettled feeling, and you kind of, you know, gloss over it and act very excited to see them, but you can't remember who they are. Fast forward 10 years, and then let's say that you're in the car and you just left your son's house. You drive down the road, which you've been on many, many times, probably hundreds really, and you come to a four-way stop sign, and suddenly you get this feeling of doom and dread because you don't know which way to turn, and you really don't know where you are. You finally panic a little and get on the cell phone, and you get help. But this is terrifying. And then you can fast forward again and take it another 10 years or 5 years, or maybe even only 3, which is really scary. And you roll over in bed and you don't recognize the person in bed with you. And the reason that I've had you do this is what these patients are experiencing. This is what they're dealing with. And I think it's really important that we realize that we have to bring all of this to the forefront. All of these cognitive problems, brain problems, these are things that people are dealing with more and more now. I used to think of Alzheimer's disease as something that affected somebody's great-great-grandfather, you know, their great-uncle was in a nursing home with Alzheimer's. And the reality is, this is getting younger and younger and younger. And yes, I am getting older and older and older, but that isn't really what I'm talking about. I mean, you know, this is hitting people in their 50s, and this is hitting people in their very early 60s, which is really a prime time in your life. And I have patients with teenagers at home. So it's time that we look at this as the new frontier. We have to have a a new approach really for cognitive problems and for dealing with these patients. Because quite frankly, if we don't, we're going to bankrupt our Medicare and the whole medical industry. We have to find a new approach. There's also something else. Now, this is my mission, because in working with these patients, you quickly begin to realize it's embarrassing. It's embarrassing to the patients. You know, oftentimes these people are very intelligent people. They've been very highly functional professionals, and suddenly, you know, they can't remember anything, or they have trouble finding their words, and they feel, quote, stupid. So I think it's so important to embrace this and understand the notion that, and I realize you know this, but that we impart this to our clients and patients, that this has nothing to do with intelligence. This is an organ that's having a problem. We don't want people to think of this as a death sentence. The truth of the matter is, that is what is thought of right now. And truly, if we don't intervene, these patients will ultimately die of this. So it is in a way, and has been for a long time, a death sentence, but that's no longer true. So I really think it's important. You know, we're opening a new office in Seattle, and I actually spoke with the family before I moved down here, and they were going to be, the wife was going to become a patient, and she was very excited. And suddenly they seemed to disappear, and I spoke with the family friend that had referred them to me, and she said a terrible thing happened. They went to their primary care doctor, who said, you have Alzheimer's disease. This is an awful thing, but you know what? Nothing's going to help you. You're going to die from this. And you can try some alternative therapies, but the reality is, this is it. And so this patient now has fallen off of my radar. I understand she's talked about suicide. So this is something we really have to be tuned into and come up with something better than this. Look at this. This is what getting the news is all about, unfortunately, in today's world. I have many, many patients, and they all tell me, you know, the doctor came in, it was the most terrifying time of my life, patted me on the back and said, I'm so sorry. There's really nothing we can do. And we can try 1 or 2 drugs, but the reality is if they help briefly, and you need to get your affairs in order. When you look at the numbers, they're staggering. 318 million Americans alive today. There's 45 million that are going to develop Alzheimer's. Think about that number. That's huge. And they expect by 2050, it's going to be greater than 160 million. So as I said, this is something we've got to do something about. It is a crisis. It's a healthcare crisis. And the ApoE genotype, which we'll talk more about, is the most important genetic risk factor. Well, there's 75 million Americans with that genotype. So we really owe it to humanity to do something about this. And these are very similar. These are the numbers really from the Alzheimer's Association. It's the 6th leading cause of death, and I've actually seen it also listed as the 3rd. So I think we really have to think about that. I have another one I put up. Really what I wanted to mention about this is that 82% of elderly people believe that they would love to have their memory checked at least yearly. And the sad thing is only 16% actually have a doctor that checks their cognition. And I think some of this may be related to the fact that the medical community believes that this is a death sentence. And so why bring this up? And as I go through cases with you, I'm going to explain how detrimental that can be for people, and how important it is to really catch this while we can. I think it's one of the most important things that we can do, really. You know, heart disease since 2000 to 2017 has decreased by 9%. Alzheimer's has increased by 145%. I mean, these numbers are scary, and what this means for our country and for humanity is also staggering and scary. The other thing, and this, I don't know how much people realize this, but at the epicenter are women. So it's much more common for women to have Alzheimer's than men. And so right now in America, if you are 65 or older, you're more likely to die of Alzheimer's than breast cancer. And Alzheimer's is more deadly than breast cancer and prostate cancer combined. So this is a very serious thing. So now let me tell you about the good part. So I actually started working with Dr. Dale Bredesen, and this is his first paper, Reversal of Cognitive Decline in Alzheimer's. And this was published in June of 2016. And this was looking at 10 patients. But the interesting thing is, so Dr. Bredesen worked at UCLA, and he'd been researching for 30 years and came up with really a functional approach for the undoing of Alzheimer's, if you will. I don't mind using the word reverse, but the truth is, right now we don't have a cure for it. The program helps people, but if you stop using the program, your symptoms will come back. So we certainly have a lot of work to do in this area. But it's interesting. So he had been looking at this and realized that there's numerous drivers for this disease, or underlying root causes, if you will. And we'll go through these in detail because I think that's really important to understand. This is really what got me. So the first time I saw Dale Bredesen, he was at Cleveland Clinic giving grand rounds, and he was talking about inhalational Alzheimer's. Think about that. I had just gone through a big mold exposure, had a lot of different, illnesses to deal with. And so this really caught my eye. And what he's talking about is, think about a direct route to the brain. So, it sort of depends on the particle size. So mold is certainly one of the things that he's talking about when he talks about inhalational Alzheimer's. Pollution. So we've had studies where we've literally taken a machine on the side of the road in LA, and I don't know if it was the 10 or which expressway it was, but during rush hour traffic, and measured the pollution. Well, then they take that same machine, put it inside the car with the person driving during rush hour traffic, and it's doubled. So that's our exposure. Then when you take rats and you actually tag the particles in the pollution and watch, they actually travel right through the brain. So we know pollution is important, and the size of the particle is really what matters. And when we talk about mold, a lot of times we're talking about mycotoxins. So these are the toxins that are produced by the mold, and they're nanoparticles. So they're very, very small. And then one of the things I put on here is CIRS, which stands for Chronic Inflammatory Response Syndrome. And that's actually a syndrome that we've seen patients develop. And I'm going to go into that in further detail. Suffice it to say that it is related to biotoxin. And as we move forward, I will explain that to you. I thought this was really interesting. So Finland has the highest Alzheimer's mortality in the world. And the thing they did, and this really does mention this in the paper, which is astounding, they believe that it's environmentally linked. So they realize that they have an environment that's cold and humid, and there are a lot of lakes and gulfs in Finland that have cyanobacterium, which is a biotoxin. And then their soil is low in selenium, which actually affects your body's ability to utilize or have glutathione work in a healthy way for you. So glutathione is our body's strongest antioxidant, very, very important for detoxification. And when people have mycotoxin toxicity, especially gliotoxin, they actually, it depletes your glutathione. And so if you lived, think about this, in an environment with low selenium in the soil, you might very well have more problems with detoxification and glutathione, hence making you ill. So when we talk about Alzheimer's up to today, I think we talk about failures. I can't think of another thing in medicine at this point that is any greater failure. So we've had over 400 drug trials failed. And from 98 to 2017, 148 failed drugs. So I think the reason, and I think we have to think about how we look at Alzheimer's disease, is this. It is not just one disease, if that makes sense. When you think about cancer, we talk about lung cancer, we talk about different types of lung cancers. We can have blood cancer, we can have brain cancer. It is cancer, it's all one disease in one way, however, many different types. And when we talk about Alzheimer's, perhaps if you can imagine that everyone can develop a disease like Alzheimer's, but having gotten there by a slightly different route, that really makes sense. And if that's the case, that may be why monotherapy fails. The other thing that's interesting with monotherapy, so most of the drugs have been targeting amyloid plaque. And no doubt, I'm not denying that amyloid isn't like carpet bombing your brain. However, we now believe that your body's actually trying to produce amyloid in an effort to help itself. So if you remove the amyloid, but you're not removing the offending problem, perhaps you're basically allowing it to just consume more of the patient or the brain, if that makes sense. So now we really want to think about this from a systems approach. Now this is from the Institute for Functional Medicine, and this is the functional medicine tree, which I think is great. Probably a lot of you are aware of this and have seen this, but we're talking about getting to the root cause. We're talking about giving substantial support to the patient. And we're talking about looking at clinical imbalances, because really that's what I do when I see these patients. So when someone comes to me with a history of cognitive problems, first of all, I like to make sure that I really dive deep. I want to do a lot of labs because I think it's very important. There's a lot of changes that have occurred over time that will make this patient either have nutritional imbalances, they may have thyroid problems, there's hormonal imbalances that we look at blood sugar problems. So we really do try to do a deep, deep dive to look at this. And you could say that this really may be where East meets West, okay? We're trying really to think of this as 21st century medicine, scientific wellness. One of the things I'm really excited about with my new clinic in Seattle is that I have an opportunity to bring the science and the clinical medicine together. And I think that's really important, because if we don't move the needle on this disease, we aren't going to get anywhere. Traditional doctors are used to looking for, what do you have? Here you have this diagnosis. We want to look at why. Why do you have this? We want to know what you have, and then we want to understand why. And we want to make sure that we look for the root cause. And it may be very different in patient to patient, because we all live in different environments. We all have different things that we are exposed to in our environments and different stressors. So this is Dr. Dale Bredesen. He is the one that came up with the new approach and developed really the theory of different types of Alzheimer's. So he gave them different classifications. I think from a educational perspective, that's a great way to look at it, because it makes it easier if you can classify something and understand what caused it. In my real clinical world, I feel like the lines get blurred, I think that, but we'll talk about that as we move forward. So we have a multimodal approach. We're not going to look at this from one thing. We understand that we have multiple causes for one disease process. Genomics are important, but I'm going to tell you, I don't think that they are the only thing that's important. And then what we do, so we're going to find out what's causing it, and we're going to try to remove the causes, and at the same time, we're going to try to build a scaffolding around a patient so that we can actually help them be supported while we're working on this. So I want you to think about this, and this is really important, and I'm going to be honest, I think when we're talking to populations of people, so I'm talking to you, you have a lot of different people out there. We have some that may be able to think of a family member or a friend or a spouse. Some people may very well be having their own personal struggles. How do you know that there's a problem? So it's going to be a memory problem that disrupts daily life. But guess what? When it's that far along, we're talking about probably a diagnosable, perhaps Alzheimer's. I mean, that's pretty far along if it's affecting your daily life. Problems with planning and solving problems. Maybe you were an accountant and now you have trouble with numbers. Difficulty completing familiar tasks at home. Confusion with time or place. And a lot of this gets laughed off and kind of, swept under the rug, if you will, as, oh, this is just typical aging. And I'm going to argue with you. I don't think that's true. I don't think that's true. Trouble with visual images and spatial relationships, very interesting. As we move forward and we explain this, those are signs and symptoms of toxicity. Word finding problems. Gosh, I think we've all probably had a moment or two where we're like, what is that word? That thing over there that we switch on and off, and, we have to struggle with that a little bit, but that's a big thing. If you find that you're having word finding problems, that can be a very telltale sign. Misplacing things, and I think we all do. So it's hard to differentiate this from just stress. And then finally, when people start really succumbing to things like this, we notice that they do have a withdrawal from social activities. They become embarrassed, and this is one of the things that we really have to keep our eyes open and look for. And I really just put this up there, and I'm sure everybody's aware, obviously. So you have a healthy brain on the left, we have mild Alzheimer's, and then severe Alzheimer's. And so really atrophy, depending on the areas of the brain that are affected, we're going to get different symptoms. And so, there's other forms of dementia as well, frontotemporal dementia, or FTD as we call it. Oftentimes we see changes in behavior and in personality, and maybe they become angry, word finding problems, calculatory problems with executive function. These are all different areas of the brain. So how do we evaluate this? And I think it's really important we do several things. So we can do a PET scan where we actually look at glucose uptake and determine if the patient has Alzheimer's. I like to do a volumetric MRI. And in the beginning, we used to do something called neuroquant, which I'm not as much in favor of. I like something called neuroreader. So what we do is we obtain an MRI of the brain without contrast, unless we feel there's a reason to do contrasted study. And they have to have the slices at a certain thickness, so everything has to be done correctly. And then we apply a software that looks at over 48 structures, looks at the right versus the left, and the total volume. And honestly, I am amazed at the information I get from that study, because you miss it on a regular MRI. I have patients who, and recently just spoke with the husband of a patient who has a hippocampal volume of less than 1%. Now that is a volume of less than 1% for people her gender and her age, but her MRI was read as normal. So it's really important that evaluations get done to the proper depth so that we can really understand what's going on with our client and patient. And obviously this is something the physician would be doing, but I wanted you to understand some of the testing that's used. We use a MoCA test, a Montreal Cognitive Assessment. This is a very easy test that we can do in office. And it's a pretty good test, really, and I'll show you one in just a moment. The mini mental status exam, I think, is not as good as the MoCA, but it's a good test as well, and it's something that can be done very easily in the office or at the home, or, you know, it doesn't require any special tools. CNS Vital Signs is a company, actually, that has developed a program online, and we can actually use this to test patients as well. And then NIH has a toolbox that they make available that will allow testing for patients. Neuropsychological testing, I think, is probably the gold standard, and it's with a neuropsychologist. Everybody doesn't have access to a neuropsychologist. So for example, a family physician might do a MoCA test. I have a neuropsychologist that will be working in my new office in Seattle, and they can then determine if they want to do really deep testing, which can take many hours, and we actually feel like that's too stressful for patients. But she can curtail the testing for the patient. This is an example of what you can get with the Montreal Cognitive Assessment, and this really is what I've been using. Just recently, MoCA, the company, is requiring physicians and practitioners and caregivers to train on the testing, because I think it's so important that we do it the same way every time, and if not, we can see really a big difference that may not be accurate. But this will test short-term memory, executive function, language, abstract thinking, attention, and orientation. And this is what a MoCA test looks like. And so a perfect score is 30, and 26 to 30 is considered normal. This is where I think we miss some things, because if you think about it, if you're a really highly functioning person and you're so successful in life and suddenly you develop a cognitive problem, we might miss it on this test. What if you get a 28? Is that normal? It probably is not normal for you. So there is a gray area here, and we're trying to figure out ways to make sure that we better assess people. I think that's the key. We believe that this illness starts decades before we ever really see it. And, you know, and then it suddenly sort of raises its head. And sometimes family think, well, I thought it was just stress, or they were working really hard, or we had this or that happen in our lives. So I think it's important that we always, we pay attention. But this is actually the test that the president had. So there you go. Genetics. That's the other key. Is this our destiny? There are genes that are very important for us to understand and know. But I think this is a really complicated thing. It's not as simple as, oh, you have the gene, you have it. There are some genes that are certainly more sinister. But the gene that I really like to talk about when I talk about Alzheimer's is the ApoE genotype. And we'll discuss it, excuse me. But the thing about it is, you have to think about epigenetics as well. And so it's not just do you have the gene, but what makes the gene manifest? What environment are we dipping our genes in? And the beauty of this is this. It doesn't have to be. It's something that you can have some control or say in by how you live your life, by where you take in your body and what you emerge your genes into, and what your choices are. When we talk about the ApoE genotype, it is, as I mentioned earlier, a gene that 75,000 people have. The ApoE4 gene, okay, which is the 4 allele, is the one that gives you the risk, actually. And so as you can see, there's an ApoE2, 3, and 4. And if you have one copy, so you get a copy from your mother and a copy from your father, if you have one copy, it can give you as much as 30% risk. If you have both copies and you're homozygous, it can actually give you a risk of up to 90%. So this is very important. And the interesting thing too is when you look at mankind and you look at, as we have evolved, when we were cave people, this was actually the gene that was the most predominant gene. This was the gene to have for obvious reasons. If you have a prevalent gene, it's usually something that more people are surviving with. So in those days when people were hunters and foraging for food, think about it. They did not have a refrigerator or a kitchen. Food was not as accessible. So they had times of fasting. This will become very important. And the other thing is, obviously, they didn't have processed foods. And so when you bring the ApoE4 person to America and you give them the standard sad American diet, I think that's when the problems begin. And so this is going to play into how we've designed the diet for these patients. So now I'm going to introduce you to the different categories of Alzheimer's. And they're broken down into categories. And as I said earlier, I think that this makes it easier from an educational perspective, but I don't think that in reality, things are packaged so easily. So we have type 1, and we think of this as inflammatory, or hot. So you can think of what causes inflammation in people. Lots of things, right? So for example, infection. Infection would be a great example of inflammatory. And then that usually propagates into other problems because clearly your body, as you know, is a whole and it doesn't have delineation. So a diet can cause inflammation, the sad standard American diet, right? And then that also can lead into glycotoxicity. So we call that the sweet kind. And so that is when you have diabetes of the brain, type 3 diabetes, if you will. And the reason I think that Dr. Bredesen delineated this as 1.5 is it really is sort of part of type 1. But we realize now that people, you get these patients or clients that will tell you, oh, I love carbs, I love sugar, I love processed foods. And those are people that really are putting themselves at risk for this. Trophic is anything that's supportive. So that's hormonal. And when I think of that, certainly we look at the sex hormones, and we find that women with Alzheimer's, women with cognitive problems respond very, very well to estradiol. We know that estrogen really interacts with amyloid plaque and helps diminish that. So estrogen is a very important part of this therapy. Thyroid is trophic. So if your thyroid is off, and sometimes people can even have subclinical hypothyroidism. So if their family doctor looked at their TSH, they might say, oh, it's fine. It's within normal limits per the lab. But the reality is we don't always use those normal limits. We use optimal limits. And so we try to optimize. And then the one that is near and dear to my heart is type 3, toxic, and we call it the vile one. And this can be so many things. So really, this is where I think you become like this sleuth and help, discover what is underlying all of these problems. So when I think of toxicity, I think of everything. I want to know that your house is safe. I want to make sure you don't have mold in your home. I think that that is the easiest exposure to have. Mold and Lyme disease are biotoxins. So they're living organisms that create toxins and make us sick. So the toxic type, I want to make sure your home is clean, you don't have mold, make sure you don't have Lyme disease. And I know that you wouldn't think of those two as being similar, but Lyme is also a biotoxin. And really it has to do with how these organisms can hide from our immune system, our innate immune system. There's actually a genetic predisposition, and this is a whole nother lecture that I would love to give someday, but it is on biotoxin illness. But suffice it to say, when we think of toxicity, we think of biotoxins, and mold and Lyme are the most common. We think of heavy metal toxicity. So, amalgams in your teeth, mercury. We think of lead. Lead is a very big problem for people. And we tend to keep these metals in our fat area, okay? So our long bones have fat and we can store them there. But guess what? Your brain has a significant amount of fat, and we can store them there. And that's really a big part of the problem. Chemotoxins. So chemotoxins are going to be environmental toxins, so chemicals, also particles, so pollution. I've had a patient from 9/11. I've had a patient who also is an executive for a big company, and she had probably several hundred paraffin candles that were burning in her office. And actually, I don't believe they were all burning at one time. I think a lot of it was also sunlight coming through her office in Manhattan, and these chemicals would be, be more airborne. And these are paraffins. They have benzene in them, and very toxic. And then obviously we can have vascular, which is the pale, and traumatic. And when we talk to these patients and we talk to these clients, the history is so important, because you may have someone who played football when they were younger, and then they also have exposures, and perhaps the woman's gone through menopause. So there you can have multiple types. And I think that is crucial to think about it, because what I find is if we don't think about it, we don't find it. So this is what we use. We use these to look at and think about. So we have inflammatory, and we have atrophic, glycotoxic, the true toxic, which is different. And these add upon each other. I think about us people as bathtubs. And so if you think about us being born as a young, clean little bathtub, and as we get older, we fill up, and we fill up with things that we are exposed to. And so as we go through life and we fill up, we eventually reach a tipping point, and that is when we get sick. I'm going to go through a little delineation that we use to determine what type of cognitive problems do you have. And I view this as a continuum. So you start with subjective cognitive impairment. So the patient or the client is aware something's wrong with their cognition, but their family and friends don't necessarily recognize it. And this is the time to intervene. So when I talk about dispelling all the myths about Alzheimer's and cognitive dysfunction, this is a big part of it, because what happens is people feel, number one, like it's hopeless, and they feel that it's embarrassing. So they keep it to themselves, and this is deadly. So I think SCI, so subjective cognitive impairment, is a great place to start with intervention. And in our office, we actually have a prevention program, because I think that's so important. But these patients, everything will be normal, and this is when you want to get them. Now they do progress, and they progress, and this is not, these are not categories that are easy for us to delineate. There, you know, it's a very difficult thing, because you get so many different people, and they have so many different backgrounds. Some are so well educated that honestly they may seem normal to us, but function normally on such a higher level. This is mild cognitive impairment, so MCI, and it's really that intermediate stage, but we can detect it, and it's certainly, they're on the fast track to Alzheimer's. Their family, friends, coworkers can recognize that there's a problem. And this is really difficult for me. You know, I am an advocate for these patients. And, you know, I think in my mind, I know so many different stories, but I had a patient who, I believe I'm going to show you a video later of this patient, but he actually, his wife noticed that there was a problem, yet the primary care physician kind of blew it off and thought it was just stress. And the neurologist said it was most likely normal. And the reality is, if you don't catch it now, you're going to have a bigger problem down the road. So when we're talking about this, we need to remember, we've got our families will often be in denial. They're terrified. Think about this. Can you imagine if it's your spouse or your loved one, you know, and all you hear is that there's nothing that can be done? Patients are going to try to cover this up. They're terrified as well. They're embarrassed, and they think nothing can be done. It's important to know the APOE status, and really, I build a program around this, so it's very important. I start with the history, and I really dig deep, and I will show you an example of a timeline in one of the cases that I review, but you've got to always just get as deep as you can. I want to know, were you full term? Was your birth good when you were born, not your children? And were you a vaginal delivery? Were you breastfed? Because you might have gut problems. We know that if you have a leaky gut, you probably have a leaky brain. And so it's very important to look at all of this. You know, things have changed in the way we approach in medicine. We do an initial lab panel that is very robust. Oftentimes, I don't hesitate to do a stool study if I'm worried about leaky gut. And I want to know about their cortisol, their stress hormone, because we know that stress, and especially cortisol, is actually toxic to the memory center of the brain, the hippocampus. Neurotransmitters. I do a lot of neurotransmitter testing. It helps with anxiety and sleep disorders. And think about it, most of your serotonin, okay, is made in your gut. If you have leaky gut, then you're probably going to be imbalanced in that area. So I think it's a great way to look. Sleep studies are important. I need to know if people are snoring. And lots of times I'll do a nocturnal pulse oximetry that I send them home with, and then we do a deeper study if we suspect. And then we want to remove dementigens. What is that? Well, dementigens are going to be Benadryl, antihistamines, H2 blockers for the gut. There's lots of different drugs, and I can include a list that are dementigens, and we don't want to continue to do damage. And you know, when you think about Benadryl, it's really a pet peeve of mine because it's included in almost every over-the-counter sleep medication. Diet, we need to review diet to the T. We need to know everything about what they eat. So I really try to get them to keep a 7-day journal before they start. And then we want to make sure that they have all the support and the tools that are available for success. Now, I have made these little orbs, and this is sort of how I view this. And honestly, this may be a little older slide. I don't like to call the diet ketogenic. We do want them in ketosis, but we don't, you know, ketogenic diet in today's world, if you look it up online, what do you get? You get Atkins and you get everything else. So I think it's really important to understand that the diet that I'm looking for and that Dr. Bredesen wrote about is we want our patients to be in ketosis. Ketosis, the ketones actually give the best energy for the brain. And it's a very efficient energy for brain, for mitochondria. Fat is very important for cells and cell membrane. So we're trying to heal this. And so a ketogenic diet using intermittent fasting is what we use, but it's predominantly plant-based. We do use animal protein, and we use it as a condiment, is what he says. But I do want to put a caveat in here, especially for those of you that are dietitians, nutritionists. You know, it's important that a toxic patient especially get enough protein. So sometimes we have to really make this diet specific for the individual. I think that's important to note. Sleep is important. They sleep 8 hours. Mindfulness, so that is really meditation. And I use a lot of biofeedback tools, the Muse headband, heart math, and then Brain HQ is something that we use for brain training. We optimize the hormones in all of the labs, and we look for toxins. So when we're organizing the data, we're thinking we're going to start with type 1, inflammation. We want to do everything we can to put out the fire. So you know you can do a diet that's anti-inflammatory. We will use supplements. I use a lot of nutraceuticals to put out the fire and remove the sources. The risk for inflammation is increased with ApoE4. If they have a leaky gut, we want to fix it. If they have viral infections, we really are starting to look at this with a much, deeper view, because we're now realizing that you can test for and determine if somebody actually has viruses that have duplicated, that are in the DNA of every cell. So that's pretty scary. And if that's the case, we're using antiviral medications now. So labs, and I know that we're not talking about labs that you're going to order, but I think a lot of us know about different labs that cause inflammation, and we're looking at these inflammatory markers. Homocysteine is something that's very important. We want to make sure that that is lower, and I actually am going to give you some lab forms later in this talk that you can refer to if you are interested, that tell you the optimal levels. When we talk about glycotoxicity, this is type 3 diabetes, and we want to make sure that we don't have any insulin resistance, and we remove sugar from the diet, we remove grains, and it's a low-carb diet. So ultimately, if we can get support for the diet, this will reverse. And so we look at the fasting insulin. We want to see it, Dr. Bredesen says less than 90, I say less than 85 for glucose. Insulin should be around 6, less than 6. Hemoglobin A1C, I like to see it below 5. Trophic, which is more frequent in 4/4s. We want to look at thyroid. We want to fix any thyroid problems. Vitamin D is a hormone. We want to fix that. If we have an elevated homocysteine, we're going to look at all of that. And this, this is probably more information than you want to know, but it's all about balance. It really and truly is. So for females especially, I'm going to fix their estradiol level. And it's funny, it's a funny time in medicine. It's a great time in medicine. But there were days that I never thought I would say, oh, sure, if you're 78, 80, I'll put you on estrogen. But today I will. We're very careful with it, but I feel that the benefit is there. So this is the panel that we look at, and we look at all of the hormones. These are labs, and I know that this is probably more detail than you want, but some of you, I have to say, in my medical team that I have here in Seattle, I have a brain health coach. She dives into all of this. Now, she doesn't treat anyone, but she has to be the fabric to help between the patient and me. And I also have a nutritionist, same thing. They're the fabric, so we're a team, we're a therapeutic team. So we have a brain health coach, we have a nutritionist who is a dietitian and a brain health coach. We have an exercise physiologist as well, who's a brain health coach. And all of these people are not practitioners, but I think it's so important that we are all on the same page. And you may find yourself interested in doing that someday. So these are the cognitive labs that we get. And as you can see, this is a ton of labs. These are the type 3 labs, and I'm not going to go into a ton of detail, but I want you to understand that when people have a biotoxin exposure, so we're talking about mold, Lyme, cyanobacterium blooms or red tide, all of those are biotoxins. And when they have that, there are markers that we can look in the blood, and those go up and they indicate inflammation. So it gives that whole chronic inflammatory response syndrome. And really, this is something that brought Dr. Dale Bredesen and myself together, because I was so acutely aware of this, because this is what I suffered with. And he and I started working together because I realized that these patients, all of these labs are abnormal with them, even though they don't have any of the normal symptoms of chronic inflammatory response syndrome. They don't have the joint pain. They just have the cognitive deficit. So when we realized that, it sort of brought this whole program to a different level. So this is the cognitive key that I use in my practice, and this is how I organize my information, because as you can see, this is a great deal of information. So we want to know the MRI, and NQ stands for NeuroQuant, but now I'm using NeuroReader. They may have had a PET scan. I don't normally order PET scans, although I can. MARCON testing is a test we do to measure, it stands for multiple antibiotic resistant coagulase negative staph. And it's a bacteria that colonizes the deep, deep sinuses. And we believe that this is another thing that adds to inflammation, very, very close to the brain. So it is something we treat. And generally speaking, it is a colonization of the bacteria that occurs from patients or that have been exposed to biotoxins. VCS testing, and this is visual contrast testing. And actually, Dr. Richie Shoemaker is a mold physician, very well known for mold specialist. And he has a site online that you can test yourself for a VCS test, because Contrast is actually a neurological test. So it is something that can indicate that, yes, you may indeed have had a problem with that. These are the genetic tests that I get. I get the ApoE, as we've talked about. The HLA is a specific test for biotoxin exposure. And there are some people that have the genetic predisposition to biotoxin exposure. And I actually am a person, I have a multi-susceptible gene. And then the other one is MTHFR, which stands for methyl tetrahydrofolate reductase. This is an enzyme that helps with methylation and detoxification. At the end of the day, it is all about supporting the patient. I tell people I'm going to build a scaffolding around you, and I'm going to make sure that you are stronger, your health will get better, your energy, and all the while we're putting together the program for diet, sleep. They're going to do brain games, mindfulness, and exercise. And when they're doing this optimally, they're going to increase BDNF in the brain, which is brain-derived neurotrophic factor. So I look at this as this is the pillar of the program. So we've got sleep. We want 8 hours of sleep. We want to make sure they don't have sleep apnea. Really have to teach people how to have good sleep hygiene. We don't watch TV in bed. We cut back on our screen exposure. So iPads, phones, TV, computers, we want to quiet things down several hours before we go to bed. And your bedroom should be like a retreat. It should be the most wonderful, relaxing place you can be. There's a lot of research coming out about EMFs today, and I think that's something that we're going to really have to pay attention to. I think 5G is going to be horrific for our health. And we are learning that EMFs actually kind of wake up viruses. You know, we all have our own sort of microbial, bacterial, viral thumbprint. And these can actually become a big problem when we're talking about this. Brain exercises, this is really interesting. So this is Posit Science. And Posit Science is a company in San Francisco. It was started by a neuroscientist, Dr. Michael Merznick. And Dr. Merznick is really kind of the father of neuroplasticity. And he has developed this great program. It's used by lots of different people, not just cognitive patients. It's used by athletes, pro athletes. It's used by people with traumatic brain injury, TBI patients. It's used with just aging populations that want to drive safer and, you know, respond quicker. And it's a program you sign up for on the computer, and it gets harder as you get better. So it can be very difficult. It moves very quickly. And I find my patients, you know, especially the patients with MCI and a little worse, really don't like it because it is difficult. So in the beginning, I recommend family or caretakers to act as a team and help them. But eventually, they get to where they love it, because you will get better and better, and it's a great sign that your memory is getting better and your brain is healthier. Mindfulness. You know, we are all stuck in a sympathetic mode, if you will. Our world is full of stress. We don't take the time as groups of people, so families, children with their parents. We need to take more time to sit down and eat dinner quietly and have that calm time. And so I really believe that a lot of these patients get stuck in that sympathetic mode, which is the way we're wired for fight or flight, but we're not supposed to be there 24/7. So guided meditation can help bring people back to parasympathetic. And one of the things I love, I use a Muse headband, and all of my patients aren't able to do this, but I personally use one. I think it's great. You put the headband on and you download the app, and it actually lets you control sort of the weather or whatever with your thoughts. And so it's basically working on feedback. It's giving you feedback and biofeedback so that you can have more of a predominant parasympathetic. There's lots of apps, and those are things I encourage people to do. Exercise, we all should be moving. This is huge. And all of these things, by the way, increase BDNF. And I'll get to that at the end. But interval training is huge for increasing BDNF. I always try to look at things that I think people would enjoy, just to give them also satisfaction in their life. The diet, we're going to dive into for a moment. It is predominantly ketogenic. I do have people check their levels, their ketone levels, using a monitor, and I have them log it and document it according to what they ate and what their readings were. We usually check first thing in the morning when they're fasting, and then we check 2 hours after breaking the fast, and then we check 2 hours before bedtime. And the levels that we want, initially Dr. Bredesen in his book wanted 0.5 to 4, but we're finding there's a sweet spot around 1.5 to 2.5 that people seem to respond better. The intermittent fasting also helps increase autophagy, which is very, very important. It's when your cells wake up and clean house. And as I said, all of this increases BDNF. So I break the diet into phases. So phase 1 is no grains, no processed foods, no sugar. That's really important. I also want to push this. In phase 2, I start adding color back in, which is starchy, because I think we get so much nutrient from these phytonutrients, and we need it. So I kind of stole this from Terry Walls, Dr. Walls, 3 cups of color every day, 3 cups of sulfur, which is going to be broccoli, Brussels sprouts, cauliflower, cabbage, onion, garlic, and the leafy greens. And the way that I like to time it is 3 hours between bed and dinner with nothing, so fasting. And I increase my hourly fast depending on your ApoE4 status. I think prevention is where we need to start. This is just kind of letting you know. I think obviously the earlier we can intervene, the better. I'm going to go through a case with you, and I know I'm running out of time, and I don't want to fly through it, but I want to review this. This is a 71-year-old male, and he was a CPA, had a family-owned business. His wife is a CPA, and she was a patient of mine. I'd never met her husband, and she'd been a patient for years, and she came in one day, and I was doing a lab review, and I noticed that her cortisol was very, very high and off the charts, and she said, "Oh, I'm so stressed. I think my husband is developing Alzheimer's." We've been to the family doctor. We've been to the neurologist. Everything was negative. I just know something's wrong. And this is the gentleman, by the way, when we did our experiment earlier, that got stuck at the stop sign on his son's road, okay? And he didn't know where he was. So basically, he has a history of hypertension, so they certainly could add vascular. He has a history of Bell's palsy. I don't know if any of you are familiar with that, but that could speak to possibly something tick-borne related. And he also, or viral, has a history of military. So perhaps he also has some sort of traumatic problem, and he snores. So, you know, low-hanging fruit, right? Lots of things to look at. He has a history of shingles. So moving forward, we did the whole workup. And what we found is that I found he needed some trophic support, and that his blood sugar was very high. So we treated all these things. He's had a great outcome, but I want to show you this. This is his timeline. So when I look at a timeline, you look back, he was born in 1945, and he kind of perked along with nothing much to talk about. And all of a sudden, you see all of these spikes, and those are his problems. And that's what gives me an inkling of how I want to hone in. His neurology consult was negative. They said they didn't think he had a problem in his MRI. I'm going to show you let him tell you his problem right now.
A retired CPA. I started having some issues probably a year or so ago, and I didn't think much about them at the time. And it seemed like that as I went through a progression that I was forgetting things, or I would get in my vehicle to go somewhere and I would take off and I would get down the road 2 or 3 miles and I would be talking to myself and saying, okay, now where am I supposed to be going? And I had a couple of other things that occurred from that particular standpoint. Is that my wife and I was coming back from my son's house one night, and I can't tell you the number of times that I have been there, and I got to a stop sign, and I had 3 directions that I could take, and I just sat there. I had no idea as to which direction I should go in. And finally, I looked at my wife and I said, you know, tell me which way to turn, because I have absolutely no idea as to which way to go. And then once I made the turn and everything began to flow at that particular point, then I was okay. But I would still have these lapses that I would get in my car to go somewhere, know where I was going, and get in the car, go down the street, and again, I'm trying to figure out, okay, now where was I going? And as this began to progress to a certain extent, and I began to, you know, be very careful about where I was going, and I didn't really say a whole lot to my wife about this from the initial standpoint, because I'm sitting there saying, well, you know, I had a memory lapse or whatever from that standpoint. And come to find out, I had a greater problem than a memory lapse. I was infected in some way, shape, or form with mold into my body. Still have no idea how I got it, but I have an idea is that we had some mold issues in our home. And we finally got all of that eradicated. At the same time, since then, I have been on a special type of a diet of what I can eat, what I can drink, what I cannot eat, and what I cannot drink. And some of my issues have begun to improve. Now when I get in the vehicle, I know where I'm going. I have no problems in getting there. As a matter of fact, since I've been on this special type of diet and also taking a lot of other medications to help eradicate my system of this, I went on a trip to visit my brother, which was 800 miles away. I went by myself. I had no issues, and I thoroughly enjoyed myself. And also, at the same time, I recently took a motorcycle trip up to the Blue Ridge Mountains with a couple of friends of mine, and I had no issues, no problems, and I felt like that I was really getting back to somewhat of being myself.
So that is a patient that has had a great outcome, and because of our time frame, was going to cut this a little bit short, but I just want to remind you.
Dr. Ross, you're okay
Yes.
with time. Don't worry about time.
Are you
You're
sure?
close. Yeah, you're close. So this is valuable.
Okay. Well, then I'll just finish up then. Thank you. So what I want to tell you then, I backtracked a little because I actually was fast forwarding my slides, but so that's an example of a patient. I just want to give you a quick lowdown. He lived in Georgia, so he was a big fried food, beer drinking, Southern guy who had to change his diet, but he did it. and he has lost 90 pounds. He's so proud of himself. He also required some thyroid support, some hormonal support, and we cleaned his house up. And that's what happens. So he's had a great outcome. I did have another patient. I'm going to give you a quick lowdown, down and dirty, so to speak. But this is a picture. This is a crazy story. I had a patient that contacted me, very sick young man, probably in his 30s, and couldn't leave his island. I know that sounds crazy. And he thought he had chronic Lyme. And I tried to work with him, but I really was never able to see him initially. And so I felt like I had lost track of him. We'd only talked on the phone, and I talked to him about, you know, things that we could do, but he couldn't come in because of horrible vertigo. The next thing I know, he sends me his mother, who has Alzheimer's, delightful lady. She was able to drive herself into the office. And through my review, I contacted him and said, you know, I think you guys probably are being exposed to mold. I really believe this is what is going on with your mother. And, you know, he poo-pooed it, laughed it off, said, no, I really don't think so. And so we kind of lost her again to follow up. This picture, amazing. He contacted me, sent this picture. He said, Dr. Ross, you're right. This is his wall that spontaneously fell in, and look at what was behind the wall. And this was causing all of his symptoms and probably, honestly, contributing a great deal to his mother's Alzheimer's. I have seen this patient since then. He's able to get off the island. They moved into an RV. They had the house remediated. I think I would have left the house, quite frankly. That looks pretty serious. But they still struggle with some mold problems, but he actually is getting somewhat better. So I think it's really, really valuable. This is what I mean. When you do a history, you've got to dig deep, and we do. This is another patient. She's very quick.
Remember me from the immersion program in last May? All I want to do is tell you thank you. What you told me, you said that you could make me better, and I'm here to tell you that you have. Got a little ways to go yet, but we've seen marked improvement, and I can't thank you enough.
So this patient actually is an ApoE 3-4, and she too was also affected by an exposure in her home. It was thyroid, it was hormonal, it was the whole thing. So putting this together, working with the diet, very supportive family. She was just on CBS. So this video was done, golly, almost 2 years ago. And then 3 months ago, she was on CBS and as a complete reversal. I don't like to use that word. I really feel like we still have no cure. We need to pursue and do the science, which is what I'm working on. But we're really at a great time in medicine. This is happening, and I think it's very exciting. Just remember the drivers of the disease. This is something you can go back over. These are things that I've treated these patients with. We use fish oil, we use curcumin, we use a lot of different supplements that help with the treatment. And hormonal is important, and these are really quick slides. Ketogenic diet. Just don't fall into the trap of thinking it's the ketogenic diet online, you know, the Atkins type diet. It's not. But each diet will have to be tweaked slightly for the patients. We do have problems with occasional, especially females, that tend to lose too much weight, and we have to bump it up a little bit. And they probably need to be eating about 70% of their calories from fat, good, healthy fats. Sleep is so important, exercise, and mindfulness. And it all has to be done together. And that's it. I am open for questions.
Thank you very much, Dr. Ross. I'm
Welcome.
a little impressed, encouraged, and scared all at once.
It's a scary thing, but I think
Right.
we need to be encouraged.
I mean, when you start with the statistics of that by 2050, there'll be 160 million of us with AD. That's half of the U.S. population of 318 million now.
That's right.
So you referenced Finland, but how do we compare to the rest of the world? Do you know that?
I do know that actually, and we're one of the top. So it really seems to me like, I really believe that we've created a very toxic world. And I don't just mean in toxins from pollution, but in every way, shape, and form, from processed foods, from, you know, pollution in the air, the chemicals that we use, that we've created such a toxicity. So it seems that this disease goes hand in hand with a civilized world, if you will. It also, I don't think I mentioned this, and I meant to, it is the #1 cause of death for women in the UK.
Yeah.
Terrifying. Yeah.
So with inhalational AD, coming mold, pollution, CRS, there's just so much of it, and I think about the hurricanes and the floods and the water damage, the long-term water damage that people are living in, and the effects that that's having.
It's terrifying.
And you know, the gentleman that case #1 that you referenced, you know, it wasn't really Alzheimer's. It was mold, right? But it was leading him to Alzheimer's. Did I get that right?
Right. Well, I mean, you know, you can develop Alzheimer's and it comes from many different causes. So certainly, you know, if you're exposed to toxicity over time, it can lead you to Alzheimer's. It's a continuum. So he definitely was headed in that direction.
No, we're seeing more and more brain inflammation for a lot of reasons. So the statistics for the ApoE4 for women particularly, I mean, the slide said 60 to 68%, and then you dropped in with 90%.
It can be up to as much as 90. Yeah, absolutely. It's scary. But it doesn't have to be that way.
I'm not saying that you were scary. The topic is scary. You were very calming through all of this, so I'm grateful for that, because you also have solutions. But it's like we have options. There's things that you've discovered and that we're still learning, and there's pathway to improvement at least.
Absolutely.
There's a question about the supplements that help. Maybe you can go back to that slide. One of them was fish oil. Are you recommending methylated B vitamins?
Well, you know what I do, I have a basic list. I'm trying to see if I can find that slide. I have a basic list that I use for patients that I sometimes start people on. So for example, fish oil is good for everyone, and predominantly DHA. So normally, normal fish oils, EPA and DHA in a 3-to-1 ratio. And so they have like a pro DHA, and I will have people start that. There is a caveat that you have to think about, and so you don't want to do it, you know, just without thinking about this. There is a thing called conjunctival hemorrhagic disease where it's predominantly in males, ApoE44. If there's a family history of CVAs or hemorrhagic strokes, then you don't want to give them too much fish oil. You want to be careful with that. But the fish oil is certainly something we start people on. I like curcumin. I mean, I'm a big proponent of it. You know, I didn't really have tremendous cognitive problems when I was sick. But although I will say, I think everybody, when they get sick, can have a brain fog or a mitochondrial problem. And who knows where that's going to take you if you don't intervene. But curcumin is great. It decreases amyloid. It also decreases the inflammation. So I think it's really good as long as people can tolerate it with their gut. And then there is a list, and if you would like for me to provide you with the basic list, I'm happy to. The methylated B vitamins, you never want to over methylate somebody. It's very rare that you're going to have a problem with that. I do check MTHFR, but almost everybody ends up on methyl B12 and then some form of methylfolate, like methyl CPG or something like that.
Okay. And here on the slide again is ketogenic diet. You're talking at least 60%, 60 to 70% fat.
That's right.
How does this compare to autoimmune protocol?
It is very similar, honestly. I mean, that's the thing about diet. When you remove the bad players, it's all very similar. I mean, we really, if I can do it in a strict way, and it depends on the patient, I'm getting rid of sugar, I'm getting rid of grain, I'm going to get rid of dairy. So we're removing all of those things. And no processed foods, obviously no alcohol, and plant-based. And I really encourage people to eat organic. Some people have trouble with the access, and so then, we go to the Dirty Dozen and the Clean 15, well-sourced protein. I do think that you just have to watch these patients or clients, because what happens is if you get these people that are too strict and they just dwindle, we don't want people losing their muscle mass. And that can happen,
I've seen that as a concern, as, initially it seems like, well, the weight loss is the inflammation that's dropping, but still there seems to be an inability to maintain weight for some women particularly.
So, well, this is really important, and I know a lot of people listening are in the nutrition field. So I make a journal, and I have people journal because we can all eat the same thing and get different results. So maybe they can tolerate a half of a sweet potato. There's a lot of things that we can do to add calories back in and help with that as well. So
okay. You mentioned glutathione. Do you recommend liposomal over another form?
I do. I definitely do. And so in the beginning, I used to really push IV glutathione for a lot of these patients. It works really well for Parkinson's patients. And, that's not realistic for everybody's life. And my patients come from everywhere. So I then do a lot of nebulized glutathione. And I also have a compounded nasal spray that I use. Then if we have to, we'll use an oral liposomal. And I like a liquid one that I think works fairly well.
Can you talk a little bit more about the compounded nasal spray?
Yes, I mean, I like it. I think that the delivery system is easy and good, as long as the patient doesn't have mark-ons. Some patients will tolerate it, and I'll use that. I also use synapsin a fair amount, which is a nasal spray that's compounded. It's nicotinamide riboside and methyl B12.
All right. Well, I was circling back, with the compounded nasal spray to Marcons, and would it be counterindicated or just not possible?
Well, I just feel like, you get a lot of biofilm and you have this whole community living there. So I treat that first, and then when they're negative, I'll switch them. And then I have a lot of people that use the nebulized and don't seem to mind it.
Interesting. Yes, I've had, some people report that, with a neti pod or some kind of a tool like that to do a saline rinse, that just nothing goes in.
Right.
And it actually creates pressure and burning just at the attempt of it, just the little drops that just get in the front of the nose.
Do you mean people treating Marcons or trying to get the glutathione?
I'm sorry, treating Marcons.
Okay, yes. I love to use biocidin. That's my favorite way to treat Marcons. And I have them make a nasal spray.
Right, but if you can't get the nasal spray to penetrate at all,
It's really difficult. I mean, honestly, because it depends on what somebody will tolerate. I mean, you know, there's trying to think of the name of it. There is a machine actually that irrigates even deeper with more pressure. But yeah, I think you have to be careful because you want to make sure that you're not increasing inflammation.
Sure, Jen, absolutely. Thank you. Question back, you know, on the supplements and liposomal, etc. Wondering if you still use Enhancer.
I do.
All right.
I absolutely do. There's probably 3 brands that I like, but Enhance is personally the one that I use. I've used it now, golly, for years and years and years.
Okay. Let me look at anything else. I think that is bringing us to the end of our questions. So I learned a lot here, and I'm hopeful from, you know, this presentation very much that there's the beginning of a pathway to resolve a great deal of the tragedy that's impacting so many. I mean, just, I don't know anybody that's escaping it either. Right in my own family, I've got a sister and a brother, and when I look at both of them, my sister, I'm the primary caregiver for her. At 70 years old, she's probably been dealing this with at least 20 years now that, you know, I look back in that way.
Wow. I'm sorry. That's
Yeah.
tough. Yeah.
It's tough, yes. And a brother who is, you know, major English professor, creative writing instructor for his career, and had to stop teaching because he couldn't remember his students' names.
Mm.
So he would just say, "You in the green shirt."
Right.
He kept teaching, you know, past what he likely should have, but he still had so much to give. And, you know, he's in the place of, I don't know where I'm driving and I can't remember words. Otherwise, you can follow a conversation and things like that. So, you know, I hope that you have a plethora of people coming to see you and overriding the medical damning information of nothing can be done. And the sooner that we can get this information out, I'm going to post this webinar wide and far as much as I can, and hope that it gets into the hands of conventional medical providers and that they can begin to see that there's hope as well.
Well, thank you. I agree. I think it's time. We need to do something.
Yes, absolutely. All right, and the time is now. Let's seize it.
That's it.
Well, it's a pleasure to have you with us, Dr. Ross. You know, I'm so grateful for the presentation, and I hope that you will come back again and continue to let us know how your program is working, as well as give us a presentation on the biotoxin illness.
I'd love to do it. I definitely will stay in touch.
All right, thank you. I want to let everybody know again, thank you again. I want to let everybody know that this presentation was recorded and it'll be available on a Hawthorn website under archived webinars in just a few days. There's a survey, it's a short survey to fill out after the webinar ends, and I can only tell you it really helps us to have your feedback and any comments about this presentation, and I do appreciate you taking the time. I want to remind you that our next webinar is August 6th when we host Dr. Catherine Alexander Anderson. She's an expert in and will be presenting on unexplained infertility. And our next All About Alumni graduate interview is on August 7th. That's a Wednesday, 12 noon Pacific time, with our Master of Science in Holistic Nutrition graduate, Angela Montoya. She's going to be presenting on her postgrad activities, accomplishments, and her challenges too. You know, we've had just so many previous terrific grad interview presentations, so I hope you'll check those archives too. And if we've inspired you to learn more about health and nutrition with all these webinars we've offered over the years, I'll remind you that Hawthorn also provides a variety of nourishing programs and courses, so I encourage you to visit our website for more details. And when you're ready for some more personalized attention, Lizette Picasso is our admission advisor and certainly can step up and help you with some more. And just a note that we've got 2 specials as a consequence of celebrating our goal of achieving national accreditation with the Distance Education Accrediting Commission. So there's a 25% tuition on our doctoral program. If you enroll and begin by October 31st, that's a $6,000 savings. And there's a 20% discount on all of our master's programs at that time. So there's more information on our website of all of this. Hope you check us out. I want to thank everybody for attending. I want to thank James Bernardinelli for engineering our webinars and always keeping things flowing so smoothly. And I'm going to conclude this presentation with another thank you again, Dr. Ross.
Thank you.
And I want to thank everybody for sharing this educational experience together. It was rich. So I wish you all the best of health. I look forward to learning more together in our upcoming webinars. And until then, I'm going to practice tending my mind, my brain, as well as happiness, compassion, and kindness, because what we practice goes stronger. So join me in this too, and we'll meet back here in a couple weeks. Thanks, everybody.